Hello, I'm Flemming Forsberg and I'm Professor of Radiology and Head of Research at the Thomas Jefferson Research and Education Institute, and today I'll be talking about principles of elastography and tissue strain imaging. So today I'm going to talk about the principles of elastography and tissue strain imaging, and this work was supported in part by the NIH. When we start talking about elasticity in imaging, obviously we contrast it to regular ultrasound imaging, and really the difference here is that in regular ultrasound imaging we are looking at the elastic properties at the molecular level. We are essentially imaging the bulk modulus of the tissues, whereas in elastography we're looking at the properties of tissue structure and organization, specifically the strain modulus. And what makes this so interesting, seen from an imager's point of view, is that we have approximately 6 orders of magnitude of variation in the strain modulus over the range of tissue structures that you meet in the human body, versus the bulk modulus, where you're really only looking at changes within 1 or at the most 2 orders of magnitude. So in theory, elastography should have a lot higher level of sensitivity. Now, this is a fundamental equation that governs elasticity imaging. It's the Young modulus given by the letter E here, and it turns out that the Young's modulus is related to stress over strain, where strain is the change in size of an object or a rod or whatever, spring, whatever it is else you're looking at, relative to the original length. So we are looking at changes in size, displacement essentially, and then F over A is force over area, so it's the stress. So what it tells you is that the elasticity is the strain multiplied by the strain is equal to the stress. Now this is a quantitative parameter that's measured in kilopascal, but most elasticity imaging systems cannot capture this directly, but really we choose to depict the strain instead, so the relative displacement as a function of time and baseline. There are some equipment coming on the market now that can do this, and we'll talk about this as we go on. Strains does not have a direct physical equivalency, but if you want to contrast it to ultrasound imaging, it's sort of the elasticity equivalent of echogenicity. It's not very well defined, but we know what it is. So the basic idea here is that all imaging is based on doing ultrasound speckle tracking and tissue motion estimation by finding out along an entire A-line, as you see here. This would be depth. You see the entire A-line here, and you want to track how this A-line changes, in other words, how the tissues move when there is some sort of externally applied stress field. So you would then obtain a second A-line, and you can see these little shifts here where the A-line has shifted because the tissues have shifted. It's those displacements that we try and measure and depict as a function over time to show strains in elastography. Now this is some of the early work on breast tissues that was done in vitro by Koskrob et al. Out of Baylor College in Texas. And they looked at different pre-compression rates and different strain rates, because a lot of the early work was done with what's called static elastography, where they used the transducer to put it on the sample or the tissue and apply a bit of force and then more force, and looking at the differences between two images, one before compression then after, to try and look and detect those displacements. Well, what they did was they did quantitative measurements, and what you see here is that the different types of breast tissue, benign lesions, of course, normal tissues, fat, glandular, and fibrous tissue, contrasted to ductal carcinoma in situ, DCI, and the various infiltrating carcinomas. And you see here that depending on what strain rates and pre-compression rates you're looking at, there are certainly regions where these numbers in the cancers stand out quite dramatically from the normal tissues. And that is essentially one of the reasons why women are asked to do self-examination of their breasts, is because a lot of cancers feel hard. There are hard lumps underneath your fingers, and that's the principle of palpation, sort of using your fingers to feel changes in stress underneath the skin. And what elasticity and elastography does is it moves that concept onto an imaging mode. So it's the ultrasound equivalent of palpation. So if you look at it as a simple tissue compression model, you can see here with the transducer before compression, then you apply compression in this case with the transducer, and then tissue structures within your region of interest marked by the red box will have shifted. You can see, some of these will have moved down, some of these will gotten flatter, some of these will have moved outside the structure. But what's important to bear in mind here is that this extremely simple model also depends extensively on the boundary conditions. Essentially, if you think about it, if you take this slab of tissue and if you put it in a steel box, then no matter how much compression you're going to put at it, objects aren't going to move laterally like this because the lateral motion will be constrained by the box. So it's not enough to say that tissues have a certain elasticity, they're stiff or they're soft or they're not hard, whatever. It also depends on what the surrounding tissues are like. If tissues are very soft but surrounded by hard tissue, you will not get to move it around as much as if you have hard tissue sitting in a lot of soft tissue. So it depends not only on the properties of the tissue itself, but also on the structure and organization of the tissues around them, boundary conditions. But once that is established, essentially we are acquiring a pre-compression RFA line, and then a set time interval t later, we will acquire a second A line after there's been some sort of induced motion either by the transducer or an external source or various other techniques which we'll talk about. But then you do cross-correlation to find the best match within the original region of interest to the second A line, and it's this shift here, this displacement over the time between firings that gives you the strain, which is what we depict in our elasticity imaging. So three basic types of algorithms exist. There is the compression using the transducer as a compression paddle, either a quasi-static, you push a bit, take an image, push, take another image, which can be quite precise and quite quantitative, but really for this to make an indent as a clinical application that can be useful to physicians, we are really looking at doing this in real time. So real-time implementations become key. There are also techniques based on an external vibration source depicted with Doppler ultrasound typically. So you vibrate all the tissues, and then that introduces local phase changes which gets picked up by the Doppler ultrasound, and you can then again, since stiff tissues don't vibrate as much, they will be depicted differently. Nowadays that is most often referred to as Sonoelastography, although Fibroadenoma was another name that was applied for techniques like this. The third general class of algorithms is referred to as acoustic radiation force imaging, or ARFI. And here we use a high intensity pulse, but high intensity means still within the diagnostic range. This is a pulse equivalent to what you used in color Doppler. But this pulse is sent into the tissue, and by doing that it generates a shear pressure, which in turn will generate shear waves that will travel out laterally from the transmission direction. And by tracking this shear wave with low intensity pulses, you can estimate what the shear velocity is, and that velocity in turn is directly proportional to the Young's modulus. So you can, with ARFI, you can do quantitative measurements of elastic modulus. So this, I think, is a pretty clear idea why static compression systems did not make it into clinical practice. It's a photograph of elastography equipment anno 2002, and you can see this huge contraption here which was used to generate very, very precise control over the pressure being applied to the patient. So this worked well as a science setup for doing excellent quantitative work, but it was really not a suitable setup for clinical utility. However, it can generate a lot of very interesting data. You can see here on top phantom measurements depicted in ultrasound sonograms, and then on the bottom the equivalent information depicted in elastograms. Now first of all, bear in mind that every time you're looking at an elastogram, you're really looking at the information from two ultrasound images. So in some sense, just looking at an elastogram, it will have twice as much information as a sonogram will. But see how the lesions that are here, sitting here, the echogenic nodules here, you can see in the first image that there is a lesion up here. You can see it very nicely in elastography. But as you go further in, this is for different signal to noise ratios, and if you change those, you can see that we get more and more acoustic shadowing, which ends up losing all information regarding the smaller lesion position posteriorly. But in the elastograms, we continue to pull enough information out, because even though we can't directly depict it, at least the differential between this image and its pre-image is enough to pick up the location of the deeper lesion of the two. This is by now an old but still famous image showing elastograms obtained in vitro of a canine prostate. So here black is soft tissues, so you can see the gland is soft around the edges, and you can see very nicely the fibrous structures that holds the prostate gland together, because they're stiffer and they show up as these white elements here. You can see the corresponding pathology images, and then the ultrasound sonogram really doesn't show any of this information. And finally, this is the equivalent MRI images that shows very nicely the correlation between the MR and the elastograms down here. At our lab, we've been looking at animal studies for quite a while, trying to investigate some of the fundamental properties of elastography. So we looked at canine prostates and livers, we looked at rapid livers, and we looked at swine with either thermal or ethanol alcohol added in order to induce lesions. And the concept here is that we were mainly interested in cancer applications, trying to figure out if we could detect or differentiate, characterize lesions based on their elasticity properties. Here's an example of a rabbit with a 6mm VX2 tumor. The sonogram is on your left and the elastogram is on its right. And what you really see is here is the lesion and here's the lesion. So the elastogram depicts the lesion significantly more clearly than the corresponding sonogram, which is a very common feature. And here's the pathological confirmation to show that same 6mm lesion. Here's an example of one of our swine studies where we've injected ethanol to deneutralize the tissues and kill it. You can see the corresponding elastogram here and the pathological correlation that matches up very, very nicely with this particular image. Given that elastography can pull data out of shadows, and given its sensitivity to depict direct changes in tissue structure and stiffness, it was early on postulated that this would be an important tool for monitoring therapies. And this is an image from Raffaele Righetti's work that was published in UMB in 2001. You see the elastogram here following a HIFU lesion in a canine liver. You can see the lesion very easily on the elastogram. Here it is on T2 MRI. But when you look at the actual sonogram, you really cannot see it. Whereas, of course, not surprisingly, on pathology, you see the image and the lesion very, very clearly. We've been looking at ethanol as a model to induce hepatic lesions in swine, looked at 5 swine with different ethanol injections, different depth. These were imaged with an old HDI 1000 scanner, and we looked at different scan techniques in order to depict it. And what essentially we get are maps like the ones you see here. We get correlation maps, displacement maps, and elastogram. What we're looking for is a region with consistently high correlation. Remember that these maps show then the direct depiction of the correlation between the pre and post compression A lines. And you go in and find one that has good high correlation with the lesion is. You can see a nice displacement here, and then match up with the corresponding elastogram. And again, you can see here the scale for the correlation map goes from 0, no correlation, to 1, and we're looking for an area with high correlation where the lesion is, which would be here. And you can see displacement within this region, but not so much the lesion would have moved outside the imaging field, and that's why you can depict the induced lesion so clearly here. Now, the ethanol-induced lesions are an interesting model to use because they really don't show up in any way, shape, or form on traditional sonograms. They're just an invisible lesion, whereas in elastograms they are very, very clear. Now, obviously, if you can't see them under ultrasound, it can be difficult to find them a priori. But with the pathology here, you can see that once we take the liver out and slice it up, that you do actually see the same lesions as depicted here in the elastogram. And when we compared the data we obtained in these swine, we found that the area of the lesion as shown by elastography correlated both with the ethanol dose and with the lesion depth, but quite satisfyingly not with the acquisition technique, and it wasn't dependent on the swine either. Now, additionally, we did mechanical testing of specimens from these studies. Because we have access to the entire liver, we could take the hepatic lesions out in some normal surrounding liver parenchyma, and this was then sent down to Houston, where they have a nanoindenter machine, which is essentially a very expensive piece of equipment that forces a cylindrical indenter about 2 millimeter in diameter, the tip of it, into the tissue. And at the same time, it uses a high-resolution actuator, so it can measure the penetration and the force applied, and therefore the Young's modulus can be calculated directly. So here we see modulus measurements for 2% and 5% precompression strain, and really it's this blocky image that's the real data, because this is 10 by 10 squares that the measurements are applied in. But if you smooth them out a bit, you can see quite clearly the lesion center here. And there's a blood vessel that's somewhat annoying, shouldn't be there, etc., etc., but really had nothing to do with it. What's important here is the fact that the lesions have, on average, a modulus of about 26 kilopascal versus about 7 in the surrounding normal liver. So not only is that statistically very significant, but there's almost an order of 4 difference between the normal tissues and the stiffer lesion. Now, in sonoelastography, or vibroelastography as it was called once, this is a technique that Kevin Parker and his group up in Rochester introduced to the world back in the late 90s. But the concept is that when a small region of elevated Young's modulus or shear modulus that's situated within an otherwise homogeneous tissue is vibrated, there is a decrease in the vibration amplitude at the lesion. So if you detect this local decrease, you should be able to form images or elastograms, but just based on a very different set of data. Here's an example from a transverse view of a prostate. You can see the grayscale lesion is up here, and the reason you can see that is there are 3 big red arrows that point at it, because otherwise you really can't see it. Whereas when you start vibrating the entire prostate, you can see that this region here will linger as a non-filling defect. In other words, the hard lesion here sits as a black cloud, whereas all the soft tissues that are being vibrated by the external vibration source shows up in green on this power Doppler image. Here's another example of their work showing, in this case, a whole mount prostate obtained after radical prostatectomy. Here's the pathology with the lesion down in this corner. The equivalent sonogram, you can to some degree see the lesion, but then in vibroelastography this stands out very, very nicely as this black defect here in the otherwise fairly uniformly green gland. Now, this concept can be taken one step further into radiation force-based shear wave excitation. And what happens here is a high intensity, well-focused ultrasound beam is sent out, because this region of excitation, depending on attenuation, speed of sound, and the intensity of the acoustic beam, will generate a radiation force given by this equation here. And this will then start shear waves to propagate laterally out from the beam. If you then fire subsequent low-intensity pulses that's shown up here, you end up with an overall overlap between the two, like depicted here. And it's those pulses that will enable you to track the velocity of the moving shear waves, and therefore the associated Young's modulus. Now, the displacements that you're inducing with the ultrasound beam at this stage are very, very small. This graph is from Palmieri's paper in ultrasonic imaging in 2006. It's obtained in a phantom. This is the excitation focal depth on the x-axis versus the displacement at the focal zone. 4 different attenuation factors, and you can see that the less attenuation there is, the more signal there is, the easier it is to push things back. But even when you have the lowest level of attenuation and gets the most displacement, we're still only looking at displacements on the order of 10 microns and thereabouts, and that's the sort of displacement that we are trying to detect and map. Here's an example of an ARFI phantom image where the conventional ARFI is like this. One of the problems in ARFI is you cannot space the A lines too closely together, because with the long pulse you'll end up getting too much local heating. But here is a 4-to-1 processing scheme that was proposed very recently in this paper in 2007, and you can see the improvements in lateral resolution relative to the conventional ARFI image here. There are many possible clinical applications. The list can go on and on, but as I mentioned, one of the things that people focused a lot of their work on initially was cancer detection and characterization for breast lesions, thyroid nodules, or maybe for prostate cancer detection. But you could certainly also look at things like thrombus in DVT, or maybe the assessment of diffuse liver disease, is the liver cirrhotic or not. An interesting concept is to look at changes in the myocardium, because the heart is contracting and relaxing all the time. It is sort of voluntarily applying pressure at all stages. So there will be displacements there due to just the beating of the heart, which can be investigated and depicted. It would also be interesting to look at plaque, hoping to differentiate solid and less dangerous plaque from more soft plaque that potentially has the ability to rupture. There are also people that are interested in musculoskeletal evaluations, because tendons ought to be fairly stiff. But if there are any rupture or anything like that, they may go a lot more soft, and that may be a way where elastography could naturally depict that. And then, as mentioned already previously, we could use it for monitoring all therapies that induce lesions or change tissue parameters, such as radiofrequency ablation or high-intensity focused ultrasound. There are currently 4 manufacturers that have elastography imaging systems for use, for sale. But I really shouldn't say imaging, because one of the 4, and this is Ecosens from Paris, France, that have the Fibroscan device, which is a non-imaging elasticity device. And essentially you have a ultrasound transducer with a piston like that, and you put it on the skin, and it'll create indentations in the skin, and this pressure wave will travel through the ribs, and you essentially get a measure of differences in propagation velocities converted into Young's moduli, so that you get a measure of how the liver is looking and how the disease stage is, because things that change the overall appearance of the liver, such as, for example, cirrhosis, could be depicted in this fashion. And at least the initial clinical trial shows that this device should have an accuracy in excess of 95%, which would be very impressive. There's been some early developments looking at elastography in studying the breast, and by now there are much larger series, but here's just to give a quick overview of some of the lesion types that we've been looking at here. And this was early work that Brian Garr from University of Vermont was involved in. You can see the sonogram here with the lesion. You can see the corresponding elastogram here. You can see the artifacts down here. The deeper you go, the more difficult it is to measure. Likewise, here you see a small breast carcinoma, and you see the equivalent elastogram here. One of the important things to consider is the fact that the elastogram looks much bigger. The lesion looks much bigger than the lesion looks in the ultrasound sonogram. And we think that has to do with the desmoplastic reactions with the cancer and the surrounding tissues that sort of infiltrating the tissues and making them stiffer than they would otherwise be, but we're just not able to depict things like that in regular ultrasound imaging. And here's a fibroadenoma. Not only can you see that the size is fairly similar to what you got originally, but also that this lesion stays black. There are some variations within it, but it's not as black as a cancer, because it's a softer and more squishy, benign fibroadenoma. If you look at the paper by Brian Garr in Radiology in '97, this is his data from that study on looking at width differences versus signal strength, where higher numbers are softer and lower numbers are harder. And they were trying to see if they could separate fibroadenoma in yellow from carcinoma in red. And the hope is that if we can categorically say that lesions that fall in this region would be benign, then there would be a chance of reducing the number of unnecessary biopsies that are performed in the breast every year. And Brian Garr went on to try and assess with ROC analysis the overall accuracy of breast elastography and found it to be on the order of 0.87, as I remember, 0.86. For elastography to become a practical clinical tool, however, we really need to move from quasi-static algorithms to real-time freehand processing, and that is what's come online now more and more with the different manufacturers. There are several groups that have explored this concept, and as I mentioned, there are currently 3 different ultrasound manufacturers that have devices on the market that can do elasticity imaging, and there is a 4th one which has this non-imaging device, which was the French company. Here's an example obtained with the Hitachi unit of a normal human prostate gland. You can see how soft the gland is along the edge of the gland here, and you can see the changes in speckle and non-speckle in here in the central core of the gland, where there are regions of soft tissue intermingled with more hard tissue. If you compare examples of cancers detected with elastography, you can see here Lesion 9 and 10 prostate cancer that were also found in this mode and in ultrasound imaging. And you can see the lesion is here, and you can see the lesion is here. So you can see it's much stiffer than the surrounding normal tissue. Again here, contrast this to the previous one where there was a clear mixture of red and blue and green, but now it really only is, more than anything, it's a larger red area indicating stiffness. You can see the relative lesion up here, lesion scale from soft to hard. Here's a prostate cancer that was only diagnosed with elastography. The arrow points out the small stiff lesion sitting here, whereas you can see the conventional grayscale and indeed even the color Doppler did not give us any indication that this patient had cancer at this location. We've also looked at 4 patients with musculoskeletal disease just as a pilot study. These people had essentially tennis elbows, and in one case they were symptomatic on one side compared to the other side that was asymptomatic. So we went in and used the probes without a compression plate again on the Hitachi system. You can see when you look at the B mode here, if you contrast the left side, you can see the tendon sitting up on top here, and you can see that maybe in the right one it's a little bit wider than the left one, but it's really only when you go to the elastograms that you appreciate that the asymptomatic tendon is very nice and stiff and has a lot of blue in it indicating hardness, whereas the symptomatic one is an odd mixture of green and red indicating all these soft tissues, because this is the tendon that has the problems. There was also one case we studied that had bilateral tennis elbows, so both elbows had problems, but the left one was more than the right, and if you look at them here you can see how the red colors indicating total softness is seen much more dominantly on the left than it is on the right, though still a mixture of red and green on either side, but we don't see that clear blue, harder depiction of the tendon that we would see in the normal images. So with that in mind, I've tried to demonstrate that you can get high quality elastograms of many organs and areas by now, but I've shown you liver, prostate and breast lesions, and in vivo of course. And it seems that very small liver lesions, less than a centimeter, that you can't see with regular sonography may indeed be depicted with very high contrast when you use elastography. And for the early observations of characterization of breast lesions and liver standards, there have been accuracies on ROC analysis above 0.86. So I don't know if I've installed you with a sense of awe, but I can say thank you very much for taking the time to listening to this lecture.